Very good evening to all. I'm Dr. Vishnu Mohan, Secretary of NNF Kerala and Organizing Secretary of IEP NeoCon 2020. On behalf of IEP NeoChap and the organizing team, I extend a warm welcome to you all to the 9th webinar of Learn from the Legends series. First, let me welcome our distinguished speaker for the day, one of the real legends in our field of neonatology, Professor Dr. Rangasamy Ramanathan from Los Angeles, USA. Welcome you, sir, to the program. To moderate the session, I welcome Dr. Karthik Nagesh from Bangalore, one of the senior most neonatologists in our country, and Dr. Uma Maheshwari, Associate Professor of Neonatology at Sri Ramachandra Medical College, Chennai. And a very warm welcome to all our dear delegates who have logged in from different parts of the world to today's session of Learn from the Legends. I request the moderators to take over for the proceedings.
Hello, thank you so much, Dr. Vishnu Mohan, for the warm welcome. I extend my warm welcome to all the learned neonatal delegates from across the different parts of the country and across overseas venues as well. At the outset, I must congratulate and also thank heartfully the organizers of this wonderful series of Learn from the Legends, which is organized by the NNF Kerala branch and the IIP NeoCon chapter, which has really enabled most of us to learn directly from the legends themselves and interact with the legends themselves in our field. Thank you so much, Dr. Manoj, Dr. Vishnu Mohan, Dr. Verma, for this privilege given to me to introduce this exciting session, subject which is after my heart, which is the use of surfactant in newborns. Some of us senior neonatologists, as Vishnu said, have had the opportunity to do neonatal care for babies about close to 3 to 4 decades in this country. And we have seen the growth of neonatology in this country from its very, very infant beginnings to what it is now. We are almost akin to whatever is the wonderful care being given elsewhere in the world. Apart from ventilation, which has probably been the most important aspect which helped save so many babies across the world, I think it is surfactant therapy, which was introduced in the late 80s, and it has been available even in this country, initially partly in the early 90s, and then late 90s, we were able to use a lot of surfactant in this country to save babies. And I think it has done a lot of wonder for babies, helping them survive better. But as we saw the introduction of more and more research, especially paradigms of research which suggested that non-invasive ventilation is better to do, avoid lung injury to babies, and therefore with the advent of antenatal steroids, early delivery room CPAP, even prophylactic CPAP, we have realized that the advantages are in trying to give non-invasive ventilation, and you're able to get babies better, especially the smaller ones seem to do better with less of chronic lung disease. So with this, the mid 2000s or even till the late 2000s saw the decrease in surfactant, but nevertheless, we did feel that in about some babies who were not able to really do well, especially the small ones who were less than 28 weeks gestation, we had realized that we need to still give them some surfactant. So a lot of research, the paradigms of which were initiated by people like Professor Ramanathan, today's legend speaker, suggested that we can probably intubate partially for some short while these small premature babies, give them surfactant, try to extubate them, and then see what they do. And that was a great paradigm shift in the way we were giving surfactant. But then what is exciting now is that even lesser invasive modes of surfactant delivery and administration can help these babies, as we are now seeing. And this is where a lot of new research has shown the advantages of less invasive surfactant administration, and even without invasion to the trying to give surfactant with a nebulized form or maybe pharyngeal instillation. These are some of the things which are very exciting researches which are going to be talked about by the legend himself, Professor Ramanathan, who has been such a close personal friend for more than 2 decades now. He is a master. He is a master of respiratory care for newborns. He's done the original work on surfactant, especially poractant, and now recently he has done the original work on synthetic surfactants. And more than being a legend and a clinically excellent person and his credentials speak for themselves. He's a very, very humble gentleman. He's a very approachable person. He has been almost like my mentor for these last 2 decades. And I've reached out to him for any problems which have been afflicting us in this country for looking after newborns. So without much ado, I'm going to ask my colleague, who's an accomplished neonatologist. She is a colleague moderator of mine, Dr. Uma Maheshwari. She is herself an associate professor of neonatology at the well-known Sri Ramachandra Medical College and Hospitals in Chennai. She's going to be probably doing the honors and introducing Professor Rangasamy Ramanathan, and then we can have a session. Roma, over to you, please.
Thank you, sir. It is not only my great privilege and pleasure to introduce Professor Rangasamy Ramanathan, the world-renowned neonatologist affiliated to multiple hospitals in Los Angeles, including Children's Hospital Los Angeles, LAC and USC MC. We take great pride in saying this. He did his medical schooling in Stanley Medical College in Chennai and his post-graduation from Institute of Child Health. He has created a magic kingdom in Los Angeles, which he describes in a short video in YouTube. During my short stay as an observer in Georgetown, Washington Hospital in Georgetown University Hospital in Washington, I happened to see the widespread use of RAM cannula. So I was wondering, what is this RAM? It is something like a computer thing. Then I came to know that it is not RAM cannula, it is ROM cannula, named after the inventor, Professor Rangasamy Ramanathan. My feet was not staying in the ground. So we are very proud of you, sir. It has been widely used all over the world, even in underdeveloped countries like Uganda. He has bagged multiple awards, and to say a few: Lifetime Achievement Award, Super Dogs, Top Dogs, Best Teacher Award, Hero of Medical Center Award. He has been the PI for many funded projects and has published his research work in many international distinguished journals. His recent publications on third-generation synthetic surfactant, as mentioned by Professor Karthik Nagesh, is mentioning noteworthy. We have to mention that it is on the third-generation synthetic surfactant on CHF 5633 compared to poractants alpha, a multicentric double-blinded RCT, where he showed similar efficacy and safety. This might open up a new window taking up to the next era of synthetic surfactant. I could go on and on. This evening is not enough. Before I hand over the session, I would like to make a gentle reminder to all the participants to post their questions in the Q&A box, not in the chat box, with their name and the place where they belong to. The truth about a last word, the truth about the life of a man is not what he does, but the legend which he creates around himself. We welcome the true legend, Professor Rangasamy Ramanathan, to deliver the lecture on surfactant therapy, INSURE versus Thrissur. Over to you, sir.
Thank you so much. Good morning or good evening, depending on where you are, which part of the world. I am really thankful to Manoj and the organizing committee for inviting me. I'm delighted to be here to talk about a topic I've been working and I love. Two things only I know: how not to intubate a baby, or I try to know or teach, and about surfactant. So today, I hope you can see my slides. Okay, so I'm going to talk about how do we give surfactant, INSURE or LISA or INREXURE. And then there is also different terminologies that are used, SURE or even SAD. I don't know who came up with a SAD mnemonic. It stands for supraglottic airway device. Conflict of interest disclosures, being a CME, I'm a consultant or a speakers bureau, or received research grant support from many organizations, companies that make surfactant or devices like Burroughs Wellcome, KC USA, AbbVie, Mead Johnson, Icaria, Carefusion, Mallinckrodt, and NeoChap products. If I receive any honorarium, I donate to a charity that helps mothers, newborns, and children globally. I have no equities and do not receive any royalty payments from any surfactant manufacturers. So we come a long way. In the 1980s, most babies were intubated, and then we decided whether we should give surfactant or not, whether prophylactic or rescue surfactant therapy. Then Professor Henrik Werder, he's actually traveling on a train somewhere in Europe today. So he said he'll try to join us, introduced the term INSURE, intubation, surfactant, and extubation. That was first reported in Scandinavia. Actually, the very first study was done in Kuwait. And I'll show you that when I talk about INSURE. And then recently a paper from Netherlands about intubation, recruitment of the lung, giving surfactant and extubating the baby. Then Lisa became very popular in the European countries, Cologne, Angela predominantly started using this, and then in Vienna and other places. MIST, minimally invasive surfactant treatment, was coined by Peter Dorgeville, and then using laryngeal mask airway, or just dropping the surfactant into pharyngeal installation. All of them have been tried, and then finally nebulization or atomization or some other things that we are looking at. Truly non-invasive surfactant administration or treatment called NIST. So we are from MIST, soon we may go to NIST in the next few years. It's very interesting and a lot of very good preclinical data on you can deliver enough surfactant to improve lung compliance, blood gases, and I'll show you at the end. So what is INSURE? Most of you know here is intubation surfactant extubation. Professor Henrik Werder from Denmark coined this term many years ago. It typically involves surfactant administration using an endotracheal tube or a feeding tube and providing positive pressure breaths, often with pre-medication or sedation. Patient is disconnected from CPAP during surfactant administration and given breaths for 2 to 5 minutes in the next extubator. The major problem is that once you give INSURE with an endotracheal tube, many of us, even today, do not extubate these babies. We leave them intubated. And also, when you are giving this positive pressure breath, you really don't have any control on the tidal volume. As you know, 4 or even 5 breaths of large tidal volumes can cause injury to the lung. The first report on INSURE, which happened in 14 patients, all of them are greater than 1,500 grams with RDS in Kuwait, no mechanical ventilation and no CPAP. There were no positive pressure breaths at all given, no way of giving it. So they said, let's go and give surfactant, 200 milligram per kilo. They gave a bovine surfactant for hyaline membrane disease. It was then called. Victorian from Sweden, when working in Kuwait, and I was interested to see the second author of this paper is Devarajan. So they, and with Tori Kurstedt and Bank Robertson's group, they gave this surfactant and they showed improvement in survival and gas exchange. This is just surfactant and nothing else, no CPAP, no ventilation. So a couple of years later, Professor Henrik Werder introduced the concept of INSURE, post-surfactant, keeping the babies on CPAP. So why INSURE? Why do you want to think about giving surfactant to babies? If the baby has RDS and CPAP fails, this is what happens. Serious morbidity happens. This an observational study by Peter Dorgeville. He showed that this is the gray bars are CPAP failures, pneumothorax, death, BPD, death or BPD as a composite outcome, or any one of these major morbidities are extremely high if the babies fail CPAP without surfactant. And this is in 25 to 28 week gestation. Similarly, even in bigger babies, 29 to 32 week gestation, if you don't give surfactant to a baby, pneumothorax incidence is significantly higher, and other differences were not statistically significant. So both in small babies and big babies, moderately big preterm babies, surfactant treatment improves the outcome. What are the reasons for INSURE failure? If the baby is less than 750 grams in one study, And in another study, even babies extremely low birth weight, just like less than 1 kilo, also the failure rates with INSURE is higher. You can predict INSURE failures by looking at some of these criteria in different studies. PF ratio less than 218 and AA ratio, arterial to alveolar PaO2, less than 0.44, or PCO2 greater than 50 millimeters of mercury. In one study, arterial to alveolar PaO2 less than 0.18. These are extremely sick babies. Normal AA ratio in a preterm baby is about 0.7 or 0.8. You can see how hypoxemic these babies are. Or some have used radiological criteria, grading criteria. So infants who fail INSURE are obviously often intubated and then continue to be mechanically ventilated. So what happens with multiple INSURE procedures? Infants who require multiple INSURE procedures had significantly lower gestational age, lower birth weight, and had more severe RDS at the beginning, and also had a higher incidence of PDA, longer duration of oxygen therapy compared to babies who responded to single INSURE group. It's clear, right? Younger gestational age, more severe RDS, even the INSURE failure rate is higher. And you can see need for mechanical ventilation is significantly increased from 15 to 23%. And there was no change in BPD in babies who are treated with a single dose or multiple doses of surfactant using INSURE technique. So how can we minimize INSURE failures? Most of the studies were done using INSURE, and then after that, babies were maintained on nasal CPAP. And nasal CPAP with or without INSURE failure rates in different randomized control trials range from 24 to 67%. So what about INSURE and maintain the babies on nasal intermittent positive pressure ventilation, or NIPPV? Here is our study we published in 2012. So babies were given early INSURE using 200 milligram per kilo poractant alpha, and then looked at the outcomes and the extubation failures. So babies were randomized to either nasal CPAP, post-INSURE, or NIPPV. In babies less than 30 weeks gestation, you can see that mechanical ventilation via the endotracheal tube at 7 days of age was 17% versus 42%. Total extubation failures needing intubation was 23% throughout the NICU stay compared to 58%. We also showed physiological BPD was lower. Oxygen at 36 weeks also significantly lower. If the babies were given surfactant and then maintained on NIPPV, you reduce the need for intubation and re-intubations, and therefore you protect the lung and reduce the risk for BPD. Again, BPD is a secondary outcome, not a primary outcome. And there was no difference in the need for additional doses, even though 21%, 4% of the more babies got surfactant, but that was not statistically significant. So what is LISA? It is known by different names: LISA, LIST, MIST. I'll show you 12 different ways it has been known. Technique involves surfactant administration in a small tube, other than an endotracheal tube, while the baby is breathing spontaneously, on nasal CPAP or on NIPPV support, typically without any pre-medication or sedation. Again, when I say typically, there are no standardized way of giving either INSURE or LISA. Depends on where, in which country you are practicing. Some have called as MIST, minimally invasive surfactant treatment, less invasive surfactant administration, avoidance of mechanical ventilation, surfactant without intubation. This is a German group, but I think it's a misnomer. When you put something through the vocal cords, to me, that's intubation. They meant surfactant without an endotracheal intubation using an endotracheal tube. Take care approach, Turkish people call that. Non-intubated surfactant application, again, a study from Germany. SONSURE, sonda nasogastrica surfactant extubation from Spain. SAINT, I even forgot what the SAINT stands for. ECAL-MIST, early CPAP and large volume MIST. MISUR, minimally invasive surfactant administration. LIST, or less invasive surfactant treatment. And SURE, just recently from India, the group published a paper. They called it as SURE, surfactant without endotracheal tube intubation. So all of them pretty much mean the same. You are not using an endotracheal tube. You have the baby who's breathing spontaneously, and typically giving it with a smaller tube, a feeding tube, umbilical arterial catheter, or different tubes. I will show you in a minute. Typically without pre-medication or sedation. But that practice may be changing as we get more experience using LISA technique. So what are the major differences, similarities, and between the two? So in need for direct laryngoscopy, both INSURE and LISA techniques do need both of them, right? So trying to get this out of my way. Need for positive pressure ventilation in INSURE, because you're using an endotracheal tube. When you give surfactant, it has to be given either with bag or on a ventilator, positive pressure breaths. Whereas here, surfactant distribution relies on spontaneous breathing. And that is why you don't want to decrease the baby's spontaneous respiratory effort with heavy sedation. Endotracheal tube, here thin catheters, feeding tube, angiocatheter, arterial catheter, or LISA catheter. Secure airway, yes, since you intubate the baby, you have a very good idea where your tube is. Whereas with the LISA technique, you have to be very careful, make sure the tube, the catheter or the tube, feeding tube you're using stays in the trachea. Vocal cord position remains abducted. Vocal cords can abduct in LISA. Sedative medications are often used because we're intubating the baby. Here, less often used, so-called awake intubation. So that's where some people have problem with it. Can we intubate a baby electively for surfactant administration without sedation or pre-medication? Well, I'll discuss about that. Tolerability, babies over 30 weeks tolerate very well. Extremely low gestation age neonates like micropreemies tolerate LISA procedure much better. Surfactant kinetics study was done by Kajsa Bolin from Stockholm, published many years ago. She looked at lung association in an animal model during INSURE and compared with LISA. This lung association of surfactant is less, and she measured dynamic compliance was also low, whereas with LISA technique, she showed better distribution of surfactant in the lung, as well as improved dynamic compliance. Here is the study. Looking at, this is spontaneous breathing, this is mechanical ventilation, this is looking at the radioactivity of labeled surfactant in preterm rabbits. And she showed that distribution of surfactant is much better compared to INSURE technique. This is time-zero control animals. And she also looked at compliance. You can see in a spontaneous breathing with the LISA technique, compliance was much improved compared to INSURE technique. So in all these patient groups, animals, Curosur 200 milligram was given by pharyngeal installation and then allowed to spontaneous breathing, that's equivalent of LISA, and then mechanically ventilated, equivalent of INSURE. So they concluded that positive pressure ventilation post-surfactant treatment impairs tissue association of exogenous surfactant and lower dynamic compliance. And also she demonstrated inactivation of the surfactant. Once you start injuring the lung, your surfactant gets inactivated, whether it's exogenous or endogenous surfactant that the babies make. So there are a number of tubes are used, nasogastric tube with the side and end hole, or just end hole, suction catheter, umbilical arterial catheters, 16-gauge angiocatheter, and LISA cath, which I'm going to discuss at the end. We are planning a study, a multi-center study in the United States. So 1.7 millimeter outer diameter, and then the classical endotracheal tube. I took this from Max Vento from Spain's review article or consensus statement published last year. So we reviewed years ago, about in 2017, we published a review article looking at techniques people are using, so-called the Cologne method. They use 4 or 5 French feeding tube, and the dose of surfactant, pre-medication, all of them are different in different studies. You can see in Cologne, they used atropine, sedation, analgesia as an option. given over 1 to 3 minutes. Again, another German study, 4 French feeding tube, given over 1 to 5 minutes. Atropine was optional. Hobart method from Australasia by Peter Dorgoville, 16 gauge angiocath, 100 to 200 milligram per kilo, much faster, given over 15 to 30 seconds. And sucrose was their pre-medicational analgesia. Again, NeoChap trial, catheter using McGill forceps, and surfactant discovered 1 to 3 minutes. Again, atropine sedation analgesics were optional. LISA method in Austria, 1.3 millimeter diameter feeding tube using a McGill forceps, 200 milligram per kilo, given over 2 to 5 minutes. No pre-medication, no sedation, no atropine. Turkish group published their paper with 5 French feeding tube, 30 to 60 seconds, no sedation. In Spain, they used 4 French feeding tube, again timing 1 to 3 minutes, atropine. Karolinska method, 5 French, cut to 30 centimeters, and atropine and fentanyl were used. E-Calvin study, 17 gauge vascular catheter, 130 millimeters long, and the dose of surfactant is 5 ml per kilo, 0.5 ml bolus over 20 to 30 seconds, and then keep repeating it. Same trial, 300 millimeter long catheter, not specified, and narcotic analgesia. NeoChap trial, feeding tube, 4 ml, not specific. As you can see, the type of tubing used or catheter use is different. The dose of surfactant use is different. And I want you to remember that there are important things when we talk about dose. And the timing, how fast you give it is also different. Pre-medication, yes, no. So again, it's not yet standardized. Let's look at the data. So there are 6 randomized controlled have been published. All of them are using Thrissur, 895 patients in this systematic review and meta-analysis by Rigo et al. From Belgium. So this is LISA or LIST, this is INSURE, and all of them are mostly on CPAP. So they looked at BPD among all patients, BPD in survivors, death or BPD as a composite outcome, or early CPAP failure, or any mechanical ventilation reported. All of them are in favor of LISA or LIST. The morbidities, no difference. No difference in PDA, no difference in PDA ligation, ROP, PBL, severe intraventricular hemorrhage, or any IVH, necrotizing enterocolitis, death or morbidity. None of them are different between these two, except death or BPD as a composite outcome was less in favor of LISA or LIST technique. Coughing and reflux, surfactant reflux was a major issue in LISA. So you have to be very careful, especially if you're using a larger volume surfactant. You need to slow down to minimize reflux and reflux-induced bradycardia and desaturations. A second, using the same studies, 6 studies, a second meta-analysis was published by Aldana Aguirre from Alberta, Canada in 2017. Again, from Germany, Gopal et al., Kanmas from Turkey, Mimia from Iran, Mohammed Iran, Bao from China, and Angela Cripps from Germany. So you can see the technique. They all called it as LISA, except China. They call it as MIST. Control group was CPAP. Control group was INSURE. In the rest of the trials, gestational age range from 26 to 34 weeks. LISA versus control. These are about 100 babies in each arm, 60 to 70 babies. A small study here, 47, 43, about 100. So totally 685. Age at randomization, typically less than 2 hours in most of the studies, except the early study by Gopal et al., less than 12 hours of age. Criteria for CPAP and FiO2, most of them use 0.3 as the criteria. Again, I want you to remember what FiO2 should we even think about giving surfactant is also changing. In 2013, they used, in Turkey, they used 0.4 as a criteria to give surfactant. Again, dosing, 100, 100, and then 200 or 200 in these 2 studies, 100, it's anywhere from 100 to 200, depending on the weight of the baby, the 2015 study. The 12 is a multi-center study, single center, multi-center, multi-center, and a multi-center trial. Pre-medication, again, as you can see, yes, no, no, Atropine only, not mentioned. Atropine only, yes, no. So they showed LISA compared to INSURE decrease the need for positive pressure ventilation, reduction in death or BPD alone, very similar to RIGO's systematic review and meta-analysis findings. You can see the odds ratio, relative risk, death or BPD at 36 weeks, 0.75, BPD at 36 weeks among survivors, also 0.72 relative risk. All of them are statistically significant. Number of babies on mechanical ventilation by 72 hours of age was also significantly lower, as well as mechanical ventilation anytime in favor of LISA compared to INSURE, and no other complications. The only thing, as I mentioned, surfactant reflux was much more common with LISA 2.52. Pulmonary hemorrhage, no difference. So what happens with LISA? Does the surfactant get distributed? So here is a very nice study, but a small study published in 2016 from Amsterdam. They looked at end expiratory lung volume and SF ratio, saturation to FiO2 ratio in 26 to 36 gestation babies on nasal CPAP, and the FiO2 was greater than 0.30. It's a prospective observation study. So they used using an umbilical catheter, Thrissur, 160 to 240 milligram per kilo, given over 1 to 3 minutes. Interestingly, they had it under direct visualization on the ocal cards. So babies, when they were getting surfactant, was not getting positive pressure. Because if you keep the mouth open with the laryngoscope, you lose a lot of the CPAP pressure. So in spite of that, using electrical impedance tomography, they looked at end expiratory lung volume. This is baseline. This is end expiratory lung volume at 1 minute, 5 minutes, 30 minutes, and 60 minutes. So within 5 minutes, you can see a significant increase in end expiratory lung volume. So even with loss of pressure, by keeping the mouth open, you are able to improve the lung volume. That means you are able to deliver surfactant into the lung. And also we can see improvement in SF ratio significantly. And this is before, this is end of surfactant treatment. And then here is done within time. 1 minute, 5 minutes, 30 or 60 minutes. You can see a statistically significant improvement in oxygenation as well as improvement in FRC, lung volume. So here is another study, very similar to what we did in 2012. Here, they gave LISA and then followed by, then randomized the babies to CPAP or NIPPV in preterm infants, 26 to 30 gestation. It's a larger study, 200 babies in this randomized control trial, and they gave 200 milligrams per kilo of poractant alpha, and mechanical ventilation by 72 hours was 13%. Almost similar to what we published. And then overall need for mechanical ventilation was also less. Interestingly, they showed surfactant reflux was also less. And remember that during NIPPV, even in adult patients who are getting bronchoscopy, you can actually decrease bradycardia and desaturations and deliver more pressure in adult patients with NIPPV compared to nasal CPAPs. Clearly, during NIPPV, you do deliver more pressure, even though there is a catheter or an LISA angiocatheter in the trachea. The diameter is so small, some are concerned that you may not be able to deliver the pressure, especially in small preemies, where the ET tube, the tracheal diameter may be 2.5 to 3 millimeters, right? So, however, you can see surfactant treatment was required only in 38% compared to 60% if they were on CPAP. Moderate to severe RDS was also lower. Number of babies requiring more than two or more doses was also lower, but not statistically significant. So very similar to what we showed a few years ago. This study was just published from Turkey, Uncle, so by Uncle et al. So what about LISA in moderate and late preterm babies? I know in developing low and middle income countries, they're not going after 23-weeker or a 25-weeker or 24-weeker in some centers, low and middle income countries. So here is a study looking at late preterm babies or moderate preterm, 32 to 36 gestation, a multi-center randomized controlled trial from Quebec, Canada. So they used MIST. So they used LISA using Surfactant or Surfactant, 4 ml per kilo via 5 French feeding tube, again under direct vision in moderately preterm infants, was associated with significant reduction in mechanical ventilation. So need for mechanical ventilation or pneumothorax needing a chest tube was 33% compared to 90%. That's pretty high. 90% incidence of pneumothorax or need for mechanical ventilation in babies between 30 to 36 weeks. I was very surprised at this number. Pneumothorax alone was not different. Number of babies requiring 2 or more doses was high, 37.5 compared to 24%, but not statistically significant, a small number. And then they gave pre-medication was atropine plus fentanyl. Surfactant reflux with the LISA technique or the MIST technique was 66%. They observed reflux of the medication. Very likely, 2 things. 1, a large volume of surfactant. 2, they kept the mouth open under direct vision while they were pushing the surfactant in. And that's why I told you, it's very important that we should continue to deliver positive pressure during LISA or MIST technique. Otherwise, you will end up losing a lot of surfactant, and you may not be able to deliver much surfactant into the lung. So here is an experience, observation study of 5-year single center experience in preterm infant between 25 to 29 weeks using LISA. They use a feeding tube, INSURE via endotracheal tube, no pre-medication, again from Ankara, Turkey. And birth weight, similar, about 1 kilo, mean gestational age 28 weeks. And they showed that mechanical ventilation within 72 hours of life was significantly lower, 27% versus 42%. This is after they started using LISA routinely in their NICU. Age at first dose of surfactant was not different, around 2 hours. So early rescue surfactant therapy. BPD, total incidence was lower, 43% versus 54%. And then moderate to severe BPD was also less. Again, it's a secondary outcome, also an observational study. So LISA treatment is associated with less need for mechanical ventilation, is associated with less moderate to severe BPD. But we already saw 6 studies that in randomized controlled trial that showed BPD was significantly less, death or BPD. So what do we do? This is our guidelines in our NICU. When we use LISA, we give atropine 20 micrograms per kilo per dose IV 4 minutes before we start the procedure. And then fentanyl 1 or 2 mics per kilo per dose, 3 minutes, given over 3 minutes. And we do keep naloxone at the bedside to reverse the effects of fentanyl, like chest wall rigidity or vocal cord spasm. May need to use vecuronium if naloxone is not effective to reverse the effect of fentanyl. Again, we don't routinely reverse it with Narcan, only if we see poor respiratory effect. Again, we use NIPPV, and therefore we support the baby, even if the baby has hypopnea, intubation at time 0. Second option is just use atropine and oral sucrose, 24%, single dose 0.2 ml for babies less than 32 weeks, or 0.4 ml for babies over 32 weeks to term. And oral sucrose effect lasts for 5 to 8 minutes. So you don't have to really rush and complete the procedure or attempt to intubate. Does LISA have any issues, complications? I told you the benefits of LISA compared to INSURE. I told you about the reflux, but here is a very large German neonatal network data. They looked at very low birth weight infants. 2,624 babies were treated with LISA. 3,095 babies were given surfactant by endotracheal tube in the years between 2009 to 2016. You can see the LISA babies were slightly bigger, 884 compared to 814. Gestation age, 26.8 compared to 26.2. Mortality was low. BPD was lower. IVH, especially grade 2 to 4, was significantly lower, nearly half. ROP requiring surgery was also half. So when they looked at the outcomes with using multivariate regression analysis, they showed that mortality odds ratio was 0.66, BPD, IVH, ROP needing surgery, However, they found focal intestinal perforation was higher, 49%, 1.49 odds ratio, range 14 to 95, 1.14 to 1.95. And then this was much more, focal intestinal perforation was much more common in babies less than 26 weeks, 10% with LISA, 7.4% with the endotracheal tube technique. So they could not explain what would have caused LISA in perforation with the LISA technique more often than with endotracheal tube, especially in micropreemies. So focal intestinal perforation needing surgery as a percentage was much higher in 22-week babies, in 23 weeks, and then after 25 and 26 weeks, there's no difference in need for surgery. And then they looked at inotropes, and chorioamnionitis, postnatal steroids. PDA drug treatment was more commonly seen in babies who got perforation. Multiple gestation, female gender was protective. Antenatal steroids didn't have much effect on this spontaneous focal intestinal perforation, again SGA. So they concluded that was seen predominantly in babies under 26 gestation. None of the other studies to date have reported this complication. So I told you, INSURE fails. LISA also will fail. So what are the risk factors for LISA or MIS to fail? They looked at about 185 babies, and they found lower surfactant dosing and no antenatal steroids. These are modifiable factors. We can modify them as clinicians. Encourage the obstetricians to give more antenatal corticosteroids, and then we, as pediatricians and neonatologists, use a larger dose. Then you will reduce missed failure. And what happens with missed failures? Missed failures result in severe IVH, decreased survival, and prolonged need for mechanical ventilation. So here is the missed failure group is in the red bar, missed success babies are in the green bar. You can see if the surfactant dose was less than 200 milligram per kilo, missed failure was 85% compared to 63%. No antenatal corticosteroid, 7.8% of the babies failed missed compared to nearly 20% of the babies. So by talking to our obstetrics colleagues, encouraging them to give antenatal corticosteroids, we can improve the outcome and we can improve the response of the surfactant in these babies. If infection like CRP was higher, probably congenital pneumonia, so they had more failures with the mist. Oxygen before the mist, higher FiO2, so more mist. So if you wait until the FiO2 is more than 0.4 or 0.5, you're going to have more failures with mist or LISA. IBH grade 3 or grade 2 or greater than grade 2 was also higher if the babies failed mist, days on mechanical ventilation. So survival without any of the serious adverse events was 57% if the babies failed mist or LISA, compared to 76% if the babies were able to successfully treat the baby with mist or LISA. Again, was 14%, 200 milligram per kilo dose compared to 35% if you use less than 200 milligram per kilo per dose. First dose. So there was another study from Netherlands looking at quality assessment and response to LISA without sedation. Should we use sedation? So it's a single center experience, again, experience in preterm infants less than 32 weeks. In 48% of the time, LISA, the first attempt failed. In 34%, quality of technical conditions, how they're holding, what the position of the baby's head, how they are trying to intubate were not proper. When the neonatologist performed LISA, the success on the first attempt was 76%. So they concluded that if you use atropine during LISA, resulted in a very low incidence of bradycardia. We know that because babies are extremely vacotonic. Anytime you touch the oropharynx with even a suction catheter, they become bradycardic, right? We all seen that in the delivery room. So giving atropine helps. They recommend that should therefore be strongly considered whether you use sedatives or not. Success with LISA may be improved with sedative pre-medication, especially in bigger babies who fight or attempt to intubate. awake intubation, I would recommend sedation. In micropreemies, at least give atropine and sucrose if you're concerned about giving. So here is the Megel forceps and feeding tube that the Cologne group uses all the time. For us in the US, and even for me, it's much easier to use an angiocatheter, LISA catheter than a feeding tube and using a Megel forceps. If you are used to nasotracheal intubation, like they do in Canada, for them, this is piece of cake. But they always intubate nasotracheally, and they use the Megel forceps to push the an ET tube into the trachea. For them, it's very easy. But in the United States, over 90% of them, neonatologists, we use orotracheal intubation. So if you're comfortable with nasotracheal, you could use the Megel forceps for your LISA technique. I hope this video plays. This is a video given by Catherine Klempermas from Vienna, a good friend of mine. And I hope this video shows up well. You can see this baby already has an IV there. You can see some blood there. You know why? They routinely give caffeine before they give LISA. So secretion, suction, Megel forceps, a feeding tube. If anybody knows Viennese language, you can tell me what she said. So they close the mouth, baby's on CPAP, and then they're pushing the surfactant. You can see, multiple videos on the YouTube or many other publications about LISA or MIS technique. So they're actually aspirating the stomach also to make sure that no surfactant getting into the stomach. Okay, so that's one technique. And then here in my own unit, this is one of my fellows giving LISA for the first time. It's a bigger baby, 30 weeks. So we gave atropine and fentanyl, and we used so I call esophagus as Grand Canyon, dark hole. Don't put anything into the Grand Canyon. You do need experience. I just want to show you this slide so that we can, when your first time you're doing it, you will be struggling. So if you want to verify, you can use a PD cap to close this in. Yeah, there it is. So if you want to verify, if you want to verify the position of the LISA catheter or angio catheter, you can actually put the PD cap. Even halfway through, you're concerned about it. Maybe they came out. Just put a PD cap and check it. It's very simple. You don't even have to open the baby's mouth, put in the laryngoscope again, and see if it's going through the vocal cords, which is much more traumatic and invasive than using a PD cap. I was very surprised that the gas the baby is exhaling can come through all the way up and picked up by the PDCAP. So Optimus trial, collaborative pair trial investigating MIST. Peter Dargaville, for many years, he was trying to do the study, 25 to 28 week gestation on CPAP or NIPPV, less than 6 hours of age, FiO2 greater than 0.30. MIST technique was used using the angio catheter. It's a 2.5 endotracheal tube for comparison. Criteria for intubation if the FiO2 was consistently greater than 0.45. Original samples were 606, but it was very difficult to enroll babies. Also, COVID delayed it even more. So the study was stopped after the DSMB reviewed the data, and 486 out of the 600, almost 500 babies have been enrolled as of March, and we will know the results very soon. So what are they doing in Germany? Who started in Denmark and Scandinavian countries. First, they started INSURE, right? Now, looking at the LISA, it's a publication from Professor Herding in last year, looking at LISA use between 2009 to 2017, a significant increase in the use of LISA, which means more babies are also getting surfactant from 2009 to 2017. Endotracheal tube surfactant treatment has come down considerably, and then surfactant, no surfactant use obviously is much lower. Then they looked at a lot of babies. This is 13,228 babies. A mechanical ventilation, 72 hours. You can see a gestation in 22 weeks, 23 weeks. Still, after LISA, over 50% of the babies stayed on mechanical ventilation by 72 hours of age, and less than 50% once you are at 25, and then at 26, less than 40%. So in bigger babies, you know, at 30 weeks, only 10 or 12% of the babies or 15% of the babies are intubated post-LISA in their neonatal network, German neonatal network. They looked at LISA was INSURE and BPD. Again, this is no surfactant. This is LISA. This is tube surfactant, INSURE. Excuse me. You can see the BPD rates are lower, but not statistically.
Sorry to interrupt, sir. The slides are not moving, sir.
Okay. Even now it's not moving?
No, sir. It is staying in that Optimus. Yes, sir. Now it's moving. It is moving, sir.
Okay. Sorry. Okay, you can see the slide now?
Yes, sir.
Thank you. So I guess I was an optimist. Okay, so this is a German neonatal network data that was published last year by Professor Herding, 13,000. You can see the LISA use is going up from 2009 to 2017, and ET tube surfactant, the INSURE technique has come down. The number of babies not getting any surfactant is obviously lower. Need for mechanical ventilation by 72 hours of life in 4,000 babies that were treated with LISA. You know, if you're a more mature baby, 29 or 30 weeks, about 20% or 15% of it is still intubated within 72 hours of life. Again, most of these units use CPAP post-LISA. BPD rates tend to be lower. The middle light gray bar is LISA. The dark gray bar is tube surfactant or INSURE. You can see in all gestational age, there's a trend towards less BPD. Again, this is a database, retrospective look at it. IVH grade 3 or 4 is also tend to be lower with LISA compared to endotracheal tube or INSURE technique in all gestational age. So this is another report from Spain, just published a few months ago in June 2020, where they looked at LISA, and this is LISA, and this is before LISA, which is INSURE. So they looked at need for mechanical ventilation, IVH, and mortality, and they showed that less IVH with LISA, which is in the red bar, purple compared to blue, pre-LISA. Number needed to treat is 5 babies. You can reduce 1 IVH, which is pretty good number. But again, historical control, not a randomized control trial. So need for mechanical ventilation was also lower on day 1, day 3, as well as day 7. Number of babies intubated in the LISA or CPAP group, with LISA was much lower. So the question comes up, I think I've convinced you that LISA is safe and feasible, works well, both in smaller babies and in bigger babies. The question is, what should be the indication for giving surfactant, whether you're using LISA or INSURE technique? 3 large observation studies have been published the last few years. This is again Peter Dargaville from Australia, Tasmania and Australia. They looked at, this is area under the curve. A value of 0.5 means no predictive power. A value of 1 means excellent, perfect, right? Nothing is perfect. So they looked at in babies between 25 to 28 gestation, on 29 to 32 gestation, the highest FiO2 value in the first 2 hours, or highest FiO2 value in the first 6 hours in bigger babies. And guess what? The cutoff was, if the FiO2 is more than 0.3 in the first hours of life, is a key predictor of CPAP failure and associated with adverse outcomes in both preterm babies below 28 weeks as well as below 32 weeks, with an area of interest of at least 0.8 in both groups, very close to 1. A second study published from Poland, looking at what FiO2 should be used surfactant, 0.3 or 0.4. They showed FiO2 of 0.29 in the second hour of life was identified as the key risk factor with an area under the curve 0.7 for CPAP failure and was associated with higher mortality and morbidity, the sensitivity of 73, specificity of 57. So very similar to what Peter Dargaville published. The third study by Kakiela et al. From Texas last year, looking at preterm babies less than 30 weeks. Again, retrospective study showed that FiO2 0.3 or greater in the second hour of life and radiographic severity RDS predicted CPAP failure. So I think now the tendency used to use 0.3 as a cutoff for the first dose of surfactant. The European consensus guidelines have also changed their recommendations to suggested protocol FiO2 more than 0.3 or 30% oxygen on CPAP of +6. Used to be +5, now they recommend +6 centimeters for early rescue surfactant treatment. What about supraglottic, there's a typo there, supraglottic airway device delivery, SAD, of laryngeal mask airway of surfactant administration. 8 studies have been published between 2004 to 2018. 1, 2, 3, 4 of them are randomized controlled trials. The other were just case reports. So the most recent one by Carrie Roberts was published. I'm going to show you the data. Here is the study published in 2018. So supraglottic airway device or LMA versus CPAP. So surfactant was given via laryngeal mask airway, and then the control group was CPAP without any surfactant, and 28 to 35 week gestation. Birth weight, minimum weight has to be 1250 because we didn't have a small enough laryngeal mask airway to put in babies less than 1 kilo or 800 grams. The FiO2 was 0.3 to 0.4. Interestingly, the control group that were on CPAP, 64% of them subsequently received surfactant anyway. So overall, treatment failures. So here is
Sir, you were
the increased need for intubation overall, 30% versus 4. Remember, these babies did not get any surfactant when this outcome was measured. Okay, did I lose you?
Yes, sir. Sorry to interrupt, sir. Your slides have gone now. So we need to reshare
Okay.
the slides.
Yeah, so where did I got disconnected? Do you know what slide?
Sir, you were, sir, once the slide plays, I could be able to tell you. Sir.
Oh, okay, sorry.
Yes, sir. This one, SAD versus CPAP.
Oh, great, okay.
The voice went off initially, after that the slides also. Yes, sir, with this slide.
Okay, thank you. So mean birth weight is about 2 kilo, 32 weeks. They gave atropine plus sucrose, 1 ml to the tip of the tongue. And they showed that LMA, surfactant given through LMA decreased the need for intubation. Odds ratio 0.30. Number needed to treat 4. However, in 18% of the babies, they had more than 50% of the surfactant dose aspirated from the stomach. So even with LMA, it's not a tight seal above the glottis. So you will lose surfactant. And they also found better response was seen in babies, subgroup of babies between 0.30 to 0.35 rather than 0.35 to 0.4. So what catheter should we use preferable? Angio catheter or Lisa catheter, so-called the Lisa cath. So this is a mannequin study. Laura Fabri et al. From Parma, Italy published this paper. They did a 5-country mannequin study by neonatologists from Austria, Belgium, Poland, Spain, and UK. Overall, neonatologists preferred using Lisa cath than the angio cath on a neonatal mannequin. And the reasons they gave why they preferred included the color, distal markings, and markings at the lip level, and soft rounded tip, and stiffness, kinkability, and lure. Both of them have lure, so they didn't have any difference in that. And potential safety, neonatologists prefer the Lisa cath than the angio cath. So are there any problems with the Lisa? And how can we correct them? Bradycardia desaturations happen, right? Whenever you try to intubate a baby. So give atropine and fentanyl. In some centers, propofol is used in Europe. Again, there's a potential neurotoxicity with propofol. So I do not recommend propofol for the time being. There's no long-term studies on propofol in a preterm baby and neurodevelopmental outcome. Apnea is another common issue. So caffeine before Lisa. Some have used ketamine, but ketamine increases the risk for apnea risk. And therefore, caffeine is better. Lisa failure on first attempt, sedation will improve your first attempt on putting a Lisa catheter.
Manage with something when that happened. Anyway, thanks. I just paused a few questions. I'll ask those questions and then hand over.
Hello. Okay. I think the panelists or somebody's talking. Okay, insertion depth. 1.5 centimeters for babies less than 27 weeks. 2 centimeters for all others. Was the Melbourne group recommendation. If you're worried about the dislodgement of the catheter, check with.
It's not create confusion now. You send me the questions then. What I should ask, or whatever I.
Hello. Okay. Coughing. So check with the EC cap or CO2 detector or PD cap. Coughing or gagging, you have to slow down the administration. You could give it over 2 or 3 minutes. Reflux, use a small caliber catheter like Lisa cath or an angio catheter. You can also use a small volume surfactant. And reverse Trendelenburg position, 12 to 15 degrees will also help to minimize the risk of reflux. Repeat Lisa procedure, if you can avoid this, use a higher dose like poractant alpha, 200 milligram per kilo. And how do we improve the Lisa success? As I said, 2 studies have been published. Use of NIPPV pre and post Lisa procedure will help you to keep the baby from getting intubated. I think Lisa here to stay. It's no longer just a fashion. So here is a study by Soumya Jeena et al., published in Pediatric Pulmonology from India. Does it work in low and middle income countries? The largest randomized control trial. There are 350 babies. I want to congratulate them. But only 50 babies are less than 28 weeks. Birth weight 1630, median 31 weeks. Time to first dose of surfactant about an hour. need for mechanical ventilation within 72 hours was significantly lower in what they call the SURE technique. That's basically LISA, 19% versus 40%. Duration of CPAP was also less. BPD rate was also lower. Necrotising enterocolitis stage 3 or greater was none, compared to 7%. Length of stay was shorter with LISA or SURE method that they called it as. And transient bradycardia and desaturation was 11%. I was really surprised that they did not document any desaturations because you remember this INSURE group in their NICU did not use any sedation in all the 3 centers. So that SURE stands for surfactant without an endotracheal intubation, or with an intubation using 16-gauge angiocatheter or 6 French feeding tube, no sedation in both arms. So they really used the same guidelines in both groups. Like one group didn't get sedation versus other group. No medication in both groups, and INSURE was given with a T-piece, so they were able to control the pressure and not with bagging. And 2 neonatologists, with experienced neonatologists, did the procedure all the time in these centers. And 3 NICUs, Lucknow, New Delhi, and Hyderabad. Again, I want to congratulate them for doing this study in a resource-limited country like India. So INSURE versus LISA, the arguments are we have no standardization neither for LISA nor for INSURE. There are differences in sedation policy, variable thresholds for pressure and FiO2 to give surfactant. And as I mentioned, INSURE technique is supposed to involve rapid administration surfactant and then extubation. So the first study by Gupta et al. From Calcutta, India, showed they didn't use any sedation. They maintained same surfactant dose and thresholds, and they gave early rescue surfactant, and they gave positive pressure only for about 182 seconds. And they used NIPPV mode in both arms, which has been shown to improve pressure transmission when airway is partially occluded. I told you adult studies have shown that. Here is the study from Calcutta, Gupta et al. Again, 28 to 34 week gestation. This is the very first study to compare same procedures for INSURE and LISA and on NIPPV in babies, preterm babies. 58 babies, 200 milligram per kilo. 29 babies got LISA method. INSURE was 29. Similar birth weight. Time to first dose an hour. Need for mechanical ventilation by half, 10% versus 21%. Not statistically significant because small number. BPD was also lower, no IVH, and length of stay was much shorter. So they used 5 French feeding tube with a McGill forceps for LISA, no sedation in both arms, and then again they decreased the duration of positive pressure breaths. So that's about LISA and INSURE. Now where do we go? So truly non-invasive surfactant treatment using nebulization or atomization is another area of interest. It's a study published using Thrissur called CureNeb study in preterm babies. This was published in Archives of Disease of Children in 2018. This number of patients intubated, 29 to 31 weeks. And the nebulized group is not significant, but in bigger babies, 32 to 34 weeks, the number of babies needing intubation was only 1 out of 11 compared to 10 out of 13. So in more mature babies, nebulized surfactant is able to decrease the need for intubation. Here is a study looking at a rabbit study. Federico Bianco from Parma, Italy has done a lot of work in animal studies using this NIST technique or nebulization technique, using a special E-flow vibrating vibrating membrane nebulizer using undiluted Thrissur. And they used 200 and 400 milligram per kilo. Both showed an improvement in PaO2, decrease in PCO2, and compliance improved. And using 200 milligram per kilo dose. There is a phase 2 clinical trial is underway. Sample size 288, 28 to 32 week gestation with RDS is registered in the European Eurodac. And I guess we need to wait for outcome. About nebulized with 400 milligram of Surf or INSURE with 200 milligram using CPAP in 1 day old newborn piglets. So they watched the lung, created RDS, and they showed that both INSURE and nebulization with Surf reduced the need for mechanical ventilation at 72 hours of age, improved lung mechanics, compliance improved, and as well as PF ratio, improved gas exchange here, improved gas exchange. So both INSURE method and nebulization works equally in this animal model. So if nebulization can work, we can totally avoid intubation. I think it's an interesting concept, but it needs to be tested in babies. So they looked at atomization, lung from Sweden, and Bianco was also one of the investigators. NIST, here the NIST is supraglottic airway device using this atomization in a piglet model, term piglets. Here is the epiglottis. This is the pharyngeal cannula that was used to deliver surfactant. And they showed that distribution using the radio-labeled surfactant with the atomization versus instillation via the endotracheal were very similar. So lung deposit, they found 40% of the lung surfactant got deposited in the lung. Typically, when you intubate give surfactant, about 80% of the surfactant gets deposited. So they were nebulized for a period of about 30 minutes. So again, another major development is a newer synthetic surfactant using peptide analogs for SPB and SPC. We just completed a trial, multi-center trial published in this month in Journal of Pediatrics, and we showed that Surf, this new synthetic surfactant works as good as Surf in terms of FiO2 needs, SF ratio improvement, were very similar in the two groups. What about INSURE? So here in this study from Italy, Vento et al. Published, they intubated the babies, placed them on high-frequency oscillatory ventilation at a mean airway pressure of 8, 15 hertz, amplitude of 15, oxygen was guided target saturation. So they show that a lung recruitment maneuver just before surfactant administration improved the efficacy of surfactant treatment in extremely preterm neonates compared with standard INSURE technique without increasing the risk for adverse neonatal outcome. But they called it as a non-invasive respiratory support strategy. I don't think so. Intubating, putting the baby on oscillator, I don't think it's, in my opinion, it's going to be practiced. So this, I guess, my last slide. So multi-center randomized control trial we are planning called the LISPAP study. Hopefully we'll start in early 2021 using LISA catheter. This is the catheter with the markings, both distally, the round soft tip, 25 to 28 week gestation on nasal non-invasive ventilation support, FiO2 0.3 or greater, saturation 88 to 95, sample size 150, 2 to 1, 100 babies to LISA, 50 babies to INSURE. This trial has been registered with clinicaltrials.gov. So we haven't started recruiting yet. So we talked about the past, present, and future is going to be, 4 major interventions in preterm babies for RDS management include antenatal corticosteroids, avoiding routine intubation, and stabilizing the babies on nasal CPAP or NIPPV, and then early rescue surfactant treatment and caffeine. Thank you very much for your attention, and be happy to answer any questions.
Thank you, sir.
Stop sharing.
Yeah.
Right? Okay.
It is always a pleasure to listen to you, Professor Ram. So your talk was so nice that we just did not realize it is almost like now more than 1 hour, and then we still want to hear more from you. But anyway, now friends, before we move on to the discussion part, there is a slight change. We will take a small commercial break for a short video clip. After 4 minutes, we'll come back for the discussions.
Yes, briefly, Professor Ola Sakstar. Thank you, Professor Ola. I hope you're doing well.
Thank you, Professor Ola, for being with us. Welcome back. As one of our moderators, Dr. Karthik Nagesh, had to leave earlier due to some unavoidable requirement, I will initiate the discussion before handing over the floor to my co-moderator, Dr. Uma. Professor Ram, there are few questions related to the length and procedure of the LISA. Dr. Ramanathan from India has asked, does the length of tube inserted relate to reflex? Dr. Indu Khosla has asked, do we need to move the position of the baby while doing the procedure? So,
I think you don't have to move the baby. Keep the baby in midline, head and a little bit elevated, 12 to 15 degrees, reverse trend run birth. And then use the same thing, lip to tip distance that you use for endotracheal intubation, like NRP suggests. That's the easiest way, 6+1, the weight of the baby. If you have markings, like the Lisa cat has, you can put in babies less than 28 weeks, 1.5 centimeters. And in babies over 28 weeks, you can insert 2 centimeters.
Thank you. Now, something related to similar, the procedure only. What is the interface for NIPPV? Deepika from UC Davis has asked, and for your 2012 study, what was the interface? Was it RAM cannula? And then again, another similar question about the maintenance of positive pressure during LISA. So what are the interfaces, and then your comments on that?
And in our center, that's a multi-center trial. So 5-center study that we published earlier. 3 centers used RAM cannula. The other two centers used Inca, Hertz, and Bronx. You can use any binasal interface that you're using in your NICU. All of them will transmit pressure. Recently a paper from India, I'm blocking his name, Murki, Srinivas, they published a paper comparing pressure transmission with face mask and Inca prongs or binasal prongs and RAM cannula. They all showed similar. You have to use a little bit higher pressure with any non-invasive interface because of the high resistance. So I would leave that to whatever you are using in your unit is fine. In terms of transmitting the pressure, I told you that adult studies have shown during bronchoscopy, if you keep them on non-invasive pressure support, they actually, patients tolerate better without desaturations. In baby studies now, 1, 2, 3 studies have been published, 2 from India, 1 from US, that showed that post-pre, if you use NIPPV, you get much better response than CPAP. So I would recommend, if it's available, you should use. If you don't have it, then just use bubble CPAP or any CPAP that you're used to.
When we work in resource limited settings, what is your take on the other tubes that like feeding tube and all other types of catheters? Like how effective will they be in the procedure?
No, I think you can use a feeding tube. The problem with feeding tube is, you need to be very well experienced using a Megel forceps because it's soft, not easy to direct into the trachea anteriorly. So if you have good experience, if you're in resource limited place in small level 2 units or community NICUs or hospitals or peripheral centers, then I don't think there'll be people with a lot of experience. That's why an angiocat, which is a little stiffer, it'd be easier to direct the catheter anteriorly with your finger into the trachea. So that's the preference. As I said, like in Canada, they always use nasotracheal intubation. So they're very good with using Megel forceps. In European countries, they use Megel forceps all the time. In the US, I've only used maybe 5 times Megel forceps in my experience, because we always do orotracheal intubations.
Okay.
So that's,
on that note, may I ask my co-moderator, because some of us are using NG tube and without anesthesia, we are doing this procedure. So like, may I ask Dr. Uma to take over and continue with the same.
Thank you, sir. So we have some question on reflex. So to ask them, like I think first question has been already asked by Dr. Manoj. Length of the tube, is there any relation to the length of the tube and reflex? That is by Dr. Rama Nagpal. And Dr. Pati Singh has asked, can we increase the dose of surfactant because there is increased reflex in the procedure? And Dr. Mohammed Tosifullah has asked, can we repeat surfactant because there is reflex? If they find the reflex, then should we repeat the surfactant?
No, I mean, length of the tube, no, doesn't matter. Length of the tube outside the baby, I'm assuming.
Yes,
because,
yes,
yeah, length of the tube outside, no. It has a lot of dead space. You need to flush it after you finish the surfactant with air so that any residual surfactant in the tubing gets delivered to the baby. So that's number 1. Typically, we use 14 or 15 or 16 millimeter long, like an ET tube length. So we don't centimeter. So we don't have to worry about the longer tube. If this is longer tube, there's a lot of surfactant stuck to the wall of the tubing, and you'll have to deliver, push it in. So preferably not use more than 30 centimeters. If you're using a feeding tube, just pre-cut it to 30 centimeters. So that way you're not wasting a lot of surfactant. In order to reduce the reflux, close the mouth, use a lower volume surfactant, and give it slowly. If you see a lot of, the only way you'll know that there's a lot of reflux is when you suction, you see a lot of this bubbly stuff in the oropharynx. Well, I don't know how much the baby got. Like in the LMA study, 50% of the surfactant was in the stomach in 18% of the babies. So the only way I would repeat the dose is if I didn't see the response that I was anticipating, improvement in oxygenation, ventilation, and I was able to reduce the FiO2 or mean airway pressure, then I would repeat the dose. And there is no time interval. You could repeat it in 2 hours or 6 hours or 12 hours, depending on the baby continues to be sick and the FiO2 is more than still 40 or 50%. X-ray didn't show any much change. Maybe it's not a simple RDS, it's probably congenital pneumonia. I would repeat the dose.
Thank you, sir. And some were kind of related to the technique. I think they kind of still wanted to know whether Lisa and Mist are one and the same. And also they wanted to know a little bit more about nebulized surfactant. What is the dose and what is the duration? And also, is there any research going on nanoparticles?
Nebulized surfactant, all the studies have been done except in the CureNeb study is on animal models. So there is a big phase 3 studies planned, phase 3 studies planned in babies. That I showed you the trial registration number in Europe, but I'm not aware of any nebulized studies in babies. So in that study, nebulized median duration was about 48 or 50 minutes. So if you have to nebulize approximately for 40 to 50 minutes. And the dose they have tried both 200 and 400 milligram in animal model, even 200 milligram nebulization, with 40% of them getting into the lung, in the animal lung model. The mass median aerodynamic diameter, which controls how much of it goes into the lung, is somewhere between 2 to 4 in those studies. But once it gets into the trachea, it picks up water and the diameter of the surfactant molecule size becomes bigger. So until it gets into the airway, even if it gets into the airway, surfactant will easily go down into the alveoli. So as long as you can get into the distal airways, you will be able to deliver more surfactant. I think that's why this special e-nebulizer, vibrating membrane nebulizer, that was patented by a group in Paris, appears to be a good one.
Is there anything on nanoparticles, sir?
No, not that I know of.
And there is some questions on catheter related questions. Is there any advantage of one catheter over the other? If feeding tube is recommended, what is the size of feeding tube to be inserted? And is there, can we use a guide wire to insert the catheter? So these are some of the questions.
Yeah, I wouldn't use a guide wire because, especially in micropreemie, the trachea is so soft. I don't know if any of you have seen the trachea in a micropreemie. It's very easy to perforate. I'm really surprised that we are not perforating many tracheas in these micropreemies, 23 and 24 weeks. It's like a noodle, like a glass tube, very little cartilage. So I wouldn't recommend using a stylet. And then feeding tube, 4 French, 5 French, 6 French, any of them could be used. In studies, they've used anywhere from 4 to 6 French. The smaller the diameter of the tube, the less chances for reflux. And I also think that like a 1.7 millimeter outer diameter NeoChap, when you give it like a mini bolus, you're actually causing a spray at the distal end of the tube, and that will easily go down rather than big droplets. So that's another reason why Lisa may work better than a big bolus of surfactant. But if you're using a higher viscosity surfactant, then you need a larger volume. If you have a low viscosity surfactant, then you don't need a huge volume. And that's the advantage of Surfactant alpha, for example.
There are some questions related where we should do Lisa. Is it in the delivery room? Where should we start?
No, don't bother about giving surfactant in the delivery room. Our goal in the delivery room is to stabilization, get a smooth transition. Yeah. Prophylactic surfactant is no longer recommended. Okay, unless the baby got intubated as part of resuscitation, then you can give surfactant. Again, you can do it in the NICU. There's no reason. In a NICU is a much well-controlled situation rather than the delivery room. I would not recommend. I don't take surfactant to the delivery room in my unit. Even if the 23-weeker mom didn't get any steroids and the likelihood baby is going to get intubated, I'm going to intubate the baby, stabilize the baby, make sure you're not giving too much oxygen, or make sure you are giving CPAP appropriately. So focus on resuscitation, avoid hypothermia, things that we can easily control in the delivery room. Bring the baby to the ICU. You have 1 to 2 hours to give surfactant, early rescue surfactant. Don't wait for 6 or 7 hours. I was looking at some questions, if the baby is on 40% oxygen, Why do you want to give surfactant? I just showed you the study. Even in LMA study, better response was seen in babies between 30 to 35. And 3 retrospective studies that showed 0.03, area under the curve was 0.7 or 0.8 to predict CPAP failure. If you go to use a drug that's expensive, that requires skill, use it early rather than wait. Yeah, occasionally some babies will get better without surfactant, but that is not, should be the general approach.
Dr. Veronica has asked, please, with all the advantage of surfactant over the years, what will it have more advocacy to governments, big pharma to shift the dialogue for low cost, effective surfactant for LMIC? So reduce neonatal mortality and morbidity.
Yeah, I'm a baby doctor, just like all of you practicing neonatologists. I don't have no control over the government regulations and the pharma industry, right? So it's a good question. We need to make it available. So, you know, maybe if the synthetic surfactant comes in, it may be available because it's easy to transport and it may be beneficial even in ARDS patients, acute RDS patients. So wherever there is, for example, meconium aspiration or surfactant inactivation conditions, yeah, I have no idea.
Yes, sir. Sir, we have few more questions on surfactant. Like,
yeah.
So till what day of life can we use surfactant, and whether, like previously, there has been a myth that we should not shake surfactant. Is it true?
You should not
shake the surfactant.
No, you gently, you know, do it, warm the surfactant. You don't want to create a lot of bubbles, so we shouldn't do that. That's in the package insert. In terms of how old the baby could be before the baby gets surfactant, there's no age limit. You know, baby got, let's say RDS, you gave surfactant, baby got better, you're able to wean, or day 7, day 10, what we call as an early phase or exudative phase of BPD, the lungs are leakier. You know, you're not fixed the anatomical problem of the canalicular lung, right? It's continuing to leak. So in those babies, evolving BPD babies, or what some people call post-surfactant slump, they act like they didn't get any surfactant. Their X-ray looks like on day 1 RDS. In those babies, we used to give steroids. Now, because of all the problems with postnatal steroid use, you want to minimize, you could give surfactant in those babies and improve the lung compliance, lung function, and try to extubate the baby. Yeah, there's no postnatal age limit for giving surfactant. People have used even a month-old baby that got surfactant in the beginning, and they've given surfactant again and showed improvement in lung compliance and ventilatory efficiency index. Pandit from Canada and a couple of studies from the US have shown that.
Thank you, sir. Sir, there is one question regarding failure of LISA. If LISA fails, the next procedure, should it be INSURE?
No, next procedure should be probably, you know, either the baby has a complicated RDS, and I don't know whether you gave a higher dose of surfactant or not. Let's say you used 100 milligrams surfactant or 135 milligrams surfactant dosing, then you need to give a second dose, and it could be given by LISA again. There's no, you know, all the studies have shown that, except for reflux, studies are in favor of LISA compared to INSURE. So I would repeat the same procedure. Doing INSURE in a baby that hasn't responded well to surfactant, that means baby's compliance is poor, still has lung disease, and if you give positive pressure, you're going to cause an injury. One suggestion somebody recommended, like Daniela De Luca says, maybe you should have a volume-controlled ventilator when you're giving surfactant, so you can accurately titrate the tidal volume, 4 or 5 ml per kilo. Is volume trauma that causes not the barotrauma, right? So that can be done, but that requires fancy ventilators and it's expensive. So I like to do things as cheap as possible, as safe as possible.
Thank you, sir. So there are some questions regarding the maintenance of pressure. So how to maintain the positive pressure? And the second question is, when should we consider NIPPV?
Pardon?
When should we consider NIPPV instead of CPAP after
okay,
the procedure?
So you're talking to a guy who uses NIPPV as the primary mode from the delivery room. In any baby with respiratory failure or respiratory distress, I start with NIPPV in the delivery room using the T-piece on my finger. Baby doesn't need it, I have it on CPAP. I bring the baby to the ICU, put the baby on NIPPV, and then see what baby does. The baby is doing well, and FiO2 is down to 25% or 21%, then I switch the baby to CPAP. So if you're using CPAP as your primary mode, when should you switch the baby to NIPPV? I think you can use the same criteria people use for intubation criteria. For example, respiratory acidosis. In spite of being on nasal CPAP, CPAP pressure is 8 or even 10, some people use, and the FiO2 is still 50, 60%, then you should start using NIPPV. But I would strongly recommend, if you can do NIPPV, you have much better benefits, even with LISA. I showed you 3 studies. I think there are many systematic reviews published, Ferguson and Lex Doyle et al. From Canada, from Australia, and Lemry from Canada. They looked at early NIPPV versus nasal CPAP, 10 randomized controlled trials, over 1,000 plus babies. They showed that early NIPPV is superior to nasal CPAP. This is their own conclusion. So I think if we can do NIPPV, the only problem is you need a ventilator. You can buy any cheap ventilator, synchronized or non-synchronized. Synchronized NIPPV is good. If you don't have it, don't get upset. It's still better than CPAP or CPAP in terms of decreasing the failures. So I would use NIPPV if you have it. If you don't have it, CPAP, and then the indication for CPAP failure and starting NIPPV would be respiratory acidosis, higher FiO2, in spite of optimizing my CPAP pressure, maybe 7 or 8 or 10 in some cases.
Thank you, sir. Do you have any experience on use of NARS on LISA during the LISA procedure?
No, I haven't done that. We have the NEARS. We are just starting to use NEARS in our babies. I'm not, there are studies looking at LISA and INSURE and cerebral blood flow using NEARS. Some studies showed that cerebral blood flow is decreased with LISA. Some studies showed no difference between these 2 modes. I think it's a good, good tool to monitor the baby during LISA or during INSURE. Again, a lot depends on are the babies well sedated or not? Is the baby hemodynamically stable? Things that alter the cerebral blood flow has to be taken into account. Obviously, if you block the ET tube, trachea with a large volume surfactant or a bolus, you're going to cause hypercarbia transiently, which will increase cerebral blood flow, increase the risk for IVA. So you have to be very, very careful when you're doing these interventions, especially in micro-preemies. Our goal is to help the babies, right? And you don't want to cause any damage in the process of treatment. That's one of the reasons why people, I think Karthik was asking me yesterday, why can't we use high flow nasal cannula after giving surfactant in big babies? I said 28 weeks or greater. I mean, why would you use a technique that you have zero idea about how much pressure is being delivered? Would you use that in any situation if it is your own patient, baby, or a family baby? I say no. Just get a bubble CPAP. At least you know what the pressure is. Why would you want to do that? It's not cheap, high flow nasal cannula, if you want a system. So just get a bubble CPAP, get a bottle of water, some vinegar, boom, you have bubble CPAP. So at least you know how much pressure you're limiting to, not necessarily how much you're delivering, you're limiting to maximum pressure. That's what I would recommend. Thank you, sir.
There are 2 questions on sedation. Why should we sedate? The second thing is it mandatory to use fentanyl and atropine during the procedure?
Okay, so atropine, I think, is a lot of people are recommending atropine because of avoiding bradycardia and desaturations, right? Number 1, because that's going to delay your procedure. Baby's heart rate goes down as soon as you put a laryngoscope. What are you going to do? Take the tube out, allow the baby to recover, right? But you give atropine, you can minimize that. It's all vaguely mediated, number 1. Number 2, studies have shown that, especially the Netherlands study, QI, Quality Improvement Report, said that if you sedate the baby, your chances of LISA is much higher, success rate. And 3, AAP, Committee of the Fetus and Newborn, also recommends in elective intubations, the baby should be given sedation. They start with fentanyl, atropine, yes or no, fentanyl, and go down. So I think most people would say awake intubation is not a good idea. Adults don't. I mean, there are a lot of reports on adults being intubated without sedation. I'm talking about 30 years ago, and they all described how bad they felt. So I don't, if you can, one, to improve the success, two, to follow the guidelines, and those are the two things I would sedate the baby. Again, fentanyl, morphine takes a long time. You know, peak effect is 10 to 15 minutes. Fentanyl, peak effect is 1 to 3 minutes. That's the reason why you're doing a procedure and getting out. So you don't want to wait until the morphine effect, peak effect takes off. That's why we use the Committee of the Fetus and Newborn also recommends fentanyl as your first choice.
Thank you, sir. We in our unit by and large do not use sedation for MIST. And MIST is the most common procedure which we use, and we use a 5 French catheter without sedation, direct laryngoscopy. The only challenge which we face is the learning curve. When a new resident is joining, we make them watch the video, and we have some simulation session for them, and we make them observe the procedure before they kind of practice.
Yeah, I mean, if you are able to successfully do it, and you look at your success rate with Lisa without sedation, you know, I would at least say sucrose. You know, babies do feel the pain. You know, for years we said, oh, babies don't feel the pain, but they do. You know, at least sucrose in the tip of the tongue keeps the baby comfortable, or colostrum if there is colostrum available within an hour or so, you could do that. That's pretty safe and very good. And we do that in all babies nowadays. I'm sure all of you are doing that. So I would still give analgesia. I don't think, you know, putting a laryngoscope into your mouth is a comfortable procedure. So, and we know newborn babies feel pain and discomfort. That's the reason I would still, at least we don't want to use opioids, just use breast milk or sucrose. Yeah.
There is one more question on the complications. So like finding surfactant in the stomach, cough, choking, laryngoscope, all seem unpredictable. Is there a way to prevent them?
No, not really. I mean, you're putting a liquid through a tube, it's going to get stuck, and you have a least resistance pathway, which is esophagus, or I call Grand Canyon. So some surfactant will go down into the stomach from the oropharynx. So the only thing we can do is maintain the positive pressure during surfactant administration and use small volume and do it slowly. There's no reason that you have to push it in within 15 seconds or 20 seconds. Just slow down. You take 1 or 3 minutes, as it's said. Some people are taking 5 minutes. Yeah, especially if you give it as a mini bolus, keeping the head end of the baby up. Mini bolus comes out like a spray, and very likely it'll go forward rather than come back up through the trachea. That's what I do.
Thank you, sir. There are like 2 questions on sedation. Can we use ketamine for sedation, and can we use midazolam instead of fentanyl?
You know, the midazolam is not an opioid, right? I mean, it's not going to. It's only a sedative, right? Not an analgesic. And we wanted an analgesic and sedative. And there are studies that midazolam or Versed use in preterm babies. I think Anand published many studies on neopain trials and showed that it's neurotoxic. Ketamine has been shown to be causes apnea. It's one thing. That's why we don't use ketamine. But there are centers that use ketamine a lot. We only use, as I said, atropine plus sucrose or atropine plus fentanyl in bigger babies to try to find it.
What is the maximum NIPPV to use before considering failing of NIPPV?
25, 30 centimeters of PIP in babies in the first 2 weeks of age. The baby established BPD, we have used 35 to 38 over 10, and still we are not able to maintain gases, then we will intubate the baby. Yeah. In about 15% of the babies in our hands fail NIPPV and get intubated. So we are able to manage majority of our babies, unless they got intubated in the DR, you know, severe RDS, 23 weeker or 24 weeker, and ended up on the oscillator. Then, you know, takes a while for us to extubate them to NIPPV. But if you start with NIPPV, and it will fail. No mode is going to work 100% of the time. In our hands, our failure rate is 50% across up to 30 weeks.
Yes, sir. Thank you, sir. Any data on effectiveness of LISA in relation to the type of interface for CPAP?
What are the question?
Any
type of
data
interface?
on the effectiveness of LISA in relation to the type of interface for CPAP?
No, I mean, there are no studies. I mean, people have used whatever interface they were using in their own units, right? LISA studies, all the studies, they do not recommend or demand that you should use one type of nasal interface. Whatever you are using, and then it's the same for LISA and INSURE, I'm assuming. That's why none of these studies, they changed. Again, a lot of these studies came out of Europe, and their nasal interface is either a mask or binasal prong. Like you saw in the Catherine Klabrama's demonstration video, they used the mask at the time of surfactant administration. So you can use nasal mask or you can use binasal prongs. You know, in our case, as I said, we use the cannula. There are no studies that I know of comparing different nasal interfaces during LISA and pressure transmission. I'm not aware of any studies.
Thank you, sir. One has asked about, like, recently Vigon has introduced Surfactant, which is slightly better and different to LISA catheter. What is your experience? Could you share, sir?
I mean, I've seen the video on their website, and I've not seen any studies using, you know, it's a nice one. It has markings on it. You can bend it at the tip. It has a black mark at the tip. So, you know, if you see the black line, you are still above the distance. It's a nice catheter, but I have no experience. I think it should work, just like LISA catheter and angio catheter. It's the only thing I can think of. The tip is not rounded. That's the only thing. Just like an angio catheter tip is not rounded tip. Other than that, it should work.
Thank you, sir. Dr. Uday Kumaran has asked, what is the advantage of caffeine before LISA?
What are the advantage of?
Usage of caffeine.
Oh, caffeine. You know, when you try to intubate the baby or even sedate the baby, they're going to become apneic, right? So that's the reason you want to improve the respiratory drive of the baby by giving caffeine. So again, it's out of practice. People are starting to do that. The only study, a small study from Netherlands, they used caffeine in the delivery room, and then they measured tidal volume, spontaneous breathing. The percentage of spontaneous sigh breaths, they call sigh breaths, was much higher in babies that were given caffeine compared to the control babies. Okay, so we know caffeine augments the respiratory drive. Caffeine increases the depth of respiration. Caffeine increases the spontaneous tidal volume compared to no caffeine. So those are the reasons why people are recommending to avoid apnea, shallow respirations, either due to sedation or during the procedure. They recommend you could give caffeine before. Are there any studies done? Randomized studies? No. Just practice. People started to use caffeine earlier and earlier. I don't use it in the delivery room, but in Vienna, they often use it in the DR. Netherlands group uses it in the delivery room. We use it in the NICU. So when you are getting ready, babies here now on NIPPV, now we decided to give LISA. We have plenty of time. So I say, okay, please go ahead and give caffeine. And then we start atropine and either fentanyl or sucrose, depending on my attending.
Thank you so much, sir. We have come to an end of the session, and it was really excellent, and we were really overwhelmed by the knowledge gained today.
Thank you so much for your kind invitation and moderating, and Manoj again for extending an invitation. I feel privileged to be in the same group as Dr. Ola Sackstad, Professor Ola Sackstad, or Satyan, who gave the talks before. It's a delight. Thank you.
Sir, kindly unmute, sir. Manoj, sir.
Thank you so much, sir. We are feeling sorry that we are taken much more time than we told we'll take, and they discussed. There are still more questions coming in, but then it's so kind of you to stay so long. At the same time, let me take the liberty of asking Professor Ola, do you want to speak few words before we wind up? Thank you so much for coming, sir.
Well, thank you. It's always a pleasure to listen to Ram's lecture. And also this time, thank you very much, Ram. I think I learned a lot. It was very, very good. Thank you. And it's a privilege to take part in these seminars, and you have done a great job.
Thank you, sir. Thank you. Thank you, Professor Ram. So now, friends, as we keep saying, all good things have to come to end. We hate to break it up, but then we need to stop. Please do join us again for a talk on HFO-VG, the recent advances in high-frequency oscillation by Professor Sandesh Luna from Spain. That will be on 14th of October. Before that, those of you who are interested in research, we have a trainees research paper competition this Sunday. You are free to log in. The details have been already circulated. That's at a different time. That is 10 a.m. Indian time. So again, our heartfelt thanks to Professor Ram for such a wonderful lecture. We hope to see you, Professor Ola, all of you next year, God willing, for the IAP NeoCon in person, if at all it happens. So we welcome you in advance for that, to Kerala for that. On that note, may I now request Dr. Pawan, the Secretary of NNF Thrissur, to propose official vote of thanks and wind up the session. Thank you. Thank you, everybody. Dr. Pawan? Okay, fine. So, friends, I think we don't need to be so formal about the whole thing. So, thank you all. We are truly humbled to have response from the representation from almost 60 countries. So, it is overwhelming. We are truly humbled by this. And then, thank you so much. Please do attend and share your experience. It's a nice experience, learning platform for us. Thank you so much. Thank you very much.
Thank you, sir. Thank you so much, sir.
Okay, be safe.
Bye.